is a vast topic, so I like to cover in two sessions. Uh, During the talk, if you're not able to follow any particular thing, please stop me and we can discuss there, or you can ask the questions at the end, whichever way you feel comfortable. I would like to try to keep it as simple as possible. I don't want to complicate giving very difficult explanations for the ECG tutorials. Um, when I was asked to talk about the ECG, like what I had in mind was I was trying to reflect myself when I was starting my house surgency way back in 1997 at a government private hospital. I was thinking how I'm going to manage my first admission day at medicine department. So I'm just focusing on those aspects and trying to make things as simple as possible. Is my voice clear or hello, Shida? Hello.
Yes, the voice is clear.
Am I audible?
Yes, sir. Audible, sir.
Yes, sir.
Yeah. Is the voice okay, or you want it to be louder?
Sir, it's fine, sir.
Fine. So we can go to the slides now. Yeah.
Yes.
Okay. Thank you. First of all, I just want to clarify, did you guys had any ECG session or any tutorials before this one?
No, sir.
Okay. So in that case, let me keep it as simple as possible. So I wanted to start from the basics, first of all, and we can gradually build up. We can even have more sessions based on how much is the requirement. Am I right in assuming that most of the audience is from the final year MBBS? Is that right?
Yes, sir.
Okay, so that I can focus on no the what is the record level of knowledge. Basically, the ECG is a representation of the electrical events of the cardiac cycle. So it's a very simple technique to find out what's going on in the heart, and also it tells us lots of various things which we are going to discuss. ECG is represented by a distinctive waveform. So each wave gives an idea about different phase of the cardiac cycle, okay, or rather the contraction of the heart chambers. So those waveforms gives us an idea depending upon how they look like or what are the variants or the changes. So we could identify various things with the ECG, such as like the most important thing why we do an ECG is to rule out any myocardial infarction or a heart attack. And we could even find arrhythmias, pericarditis, cardiac chamber hypertrophy, electrolyte disturbances, such as hyperkalemia, and drug toxicities can be sometimes picked up on the ECGs, such as the digoxin toxicity. So how we get the ECGs with the electrodes or the leads placed on the skin, we could record the tracings from the heart. How this happens is there's a term called depolarization. I'm sure you must have heard about it. Contraction of any muscle is associated with some electrical changes called depolarization. These changes can be detected by electrodes attached to the surface of the body. You must have heard about the pacemaker of the heart. Okay. Basically, there's a main pacemaker called sinoatrial node, which is the main or the dominant pacemaker. It beats roughly between 60 to 100 beats per minute, and that's the main pacemaker. And also, if there's any problem with the SA node, sometimes we have a backup pacemaker in the form of AV node, atrioventricular node, that beats roughly between 40 to 60 beats per minute. And there's also a ventricular pacemaker situated within the ventricle, which gives a very low intrinsic rate, about like around 30 to 40 beats per minute. These are all backup pacemakers. So the ECG paper is standardized in the form of 25 millimeter. That's the speed of the ECG the paper. It's 25 millimeter per second. How we get the waveforms or the impulses is like any impulse travels towards the electrode, produces a positive or upright deflection. Away from the electrode, it produces a negative deflection. That's a simple thing, concept. So just to give an idea about how all these things mechanism works is, if you look at the sinoatrial node, it's in the right atrium, okay, and it just transmits the impulse and it goes to the AV node, and it just goes to the bundle of his to the right and left bundle branches, and to the Purkinje fibers or the specialized fibers, which helps with the conduction of the electrical impulses to the rest of the heart. This is the waveform, the ECG waveform, PQRST, and I will explain to you in a minute about what are they stand for, or how it happens, or when it happens rather. P wave, the first wave the ECG phase is atrial depolarization. That means whenever the atria contracts, that gives a P wave. Actually, it's a very sequential and very interesting phenomenon happens in the heart. All the chambers, they don't contract at the same time. If you imagine, the main function of the heart is to pump the blood from, it just gets from the lungs and it just pumps into the rest of the body, like oxygenated blood is transferred to the rest of the body through the heart. So for it to be a very coordinated way of functioning, these chambers, they contract in a very orderly fashion. When it gets disorderly, then only all the problems occurs. Though initially the atria contracts and it transmits the blood from the atria into the ventricles, and the ventricles start to pump the blood into the rest of the body through the aorta. As you know, like from the right ventricle, right atrium to right ventricle and to the lungs, and from the lungs, the oxygenated blood comes into the left side chambers, and from the left atrium and into the left ventricle, and through the aorta it goes to the rest of the body as oxygenated blood. Okay, so the P wave is the atrial depolarization or the atrial contraction. The QRS complex it stands for the ventricular depolarization, which helps to transmit the blood further into the aorta. The T wave is ventricular repolarization. So for every action, there's an opposite reaction. For if any contraction happens in muscle, it needs to relax. That's the repolarization stage. So that's a waves. Like if you look at it, P wave, QRS complex, and T wave. Also, there's different things you could notify: the PR interval and ST segment and QRS intervals. I will discuss this in the further slides about how much should be the duration or what should follow which one. To keep it simple, all ECG should start with the P wave. If something is missing, if this small hump is missing, that means there's some abnormality. So we have to look for the abnormality, which we are going to discuss in the second session with a case-based discussion. But first of all, I wanted to re-emphasize the importance of knowing the basics. If you know the ECG basics, then you can become a master soon. It's not very difficult. So when I look back, way back in my during house surgery, especially during the casualty, the duties and all, when you get the ECG, the important thing is we'll try to get the help of our seniors, like PGs, to know what's going on, and we try to learn from them. So you guys are in the final year of your MBBS, or you'll be going to house surgery soon. So you will need to know the ECG. ECG learning, don't think that it's hard. If you're not able to manage knowing everything in the first go, it's an ongoing process. I finished my house surgery in '97. I'm still learning this. So there's a lot of things you can learn. There's nothing stops you from learning. So the only thing is you need to have a hunger for learning. Okay, The PR interval is the start of the P wave and up to the R wave, start of the R wave. So that's called PR interval. What does the intervals signifies is the atrial depolarization and the delay in AV junction. If you imagine, I told you like now the pacemaker is in the sinoatrial node. There's a coordinated conduction in the heart chambers. Even if the sinoatrial node starts to beat fast or rapidly, there is a filtering mechanism at the level of AV node, and not all the conductions are like if there's rapid, then there's one-to-one transmission. Sometimes like there's always a mechanism for a negative feedback at the level of AV node, which we'll discuss when we discuss about the heart blocks. Okay, so this probably gives a better idea of the normal looking ECG. So when you have this is isoelectric line, when you look at the ECG trace, the first hump is the P wave, and there's a second complex, the QRS one. It's a small Q wave followed by a big R wave and a small S wave, or rather deep S wave. This is the ST segment. This is all called isoelectric line. The reason I'm stressing on this isoelectric line is when you start looking for any ST segment elevation, or somebody comes with chest pain and they're looking for the heart attack symptoms, you will be looking at this main thing, whether this ST segment elevation or depression. Okay, so we'll discuss that as a separate lecture. And this is a T wave. Like usually, the T wave is like it's upright. So, if you are you able to see this bottom, the trace, ECG trace?
Yes, sir.
Yeah. Okay. So this is just a snapshot of the ECG paper, how it looks like. This is a normal ECG where you have a small P wave before each QRS complexes. So the P wave should occur before the QRS complex, which is this spike. So if there's P wave is missing, or if it falls on the QRS complex, or if it happens after the QRS complex, that means it's not normal, it's abnormal, and there's various reasons for that. Okay. So if you look at this ECG paper, I'm not sure whether you could be able to see it clearly. There's a big boxes, and in between these big boxes, there are tiny small boxes, which has been highlighted. This one of these boxes has been highlighted like this here. So each big box will have 5 small boxes. The reason why we need to know is like when we counting the heart rate, because these days we get the 12 ECG gives a heart rate straight away. But sometimes if you don't have the heart rate, or if it's irregular, for example, in the atrial fibrillation, where we will need to calculate the heart rate manually using these small boxes. Each small box will be equivalent to the timing of 0.04 seconds. The whole small box is 0.2 seconds. Okay. So anybody would like to give a guess how many leads do we use for recording an ECG? Don't worry, like if you're wrong, like just learn. Anyone want to answer? How many leads? We call it a 12 lead ECG. You guys must have heard about it, isn't it?
Yes, sir.
Am I audible?
Yes,
sir.
sir.
Yeah, but so you know that the ECG paper we have what we call as a 12 lead ECG. Actually, we have only 10 leads while we do the ECG, but we'll get 12 leads appearing on the trace. I will tell you. The 2 different types of leads we use. It's called bipolar leads and unipolar leads. Bipolar leads, they measure the voltage between 2 different points in the body. I will show you in a minute where to record or how to record the ECG. Or rather, we can go to the slide and we can come back. Okay. So, any guess from anyone what is the location for doing ECGs? You might need to do ECGs during house urgency. In emergencies, you might need to do if there's no technician. So, anyone knows where's the location you place these leads? Don't worry if you don't know. Okay. So this angle of Louis, like you have go down from the second space to the fourth intercostal space. The V1 is the chest leads. So you start putting the leads on the fourth intercostal space, just on the right side of the sternum bone. That's a V1 lead, and V2 is parallel to it on the left side. And V4, like just leave the V3 for a minute. V4 lead is on the fifth intercostal space, just the level of the mid clavicular line. And the V3 lead is placed between V2 and V4. And the V5 lead is placed at the level of anterior axillary line, and the same fifth intercostal space. And V6 is placed at the level of mid axillary line, in the same fifth intercostal space. Yeah, just for information, you could read these things which I will explain to you. And the limb leads are placed like this: right upper limb lead, left upper limb lead, okay, and the foot lead. The reason why we place the leads, the chest leads, in that fashion is, if you look at it, this is the coronal section of the chest, like diagrammatic representation. V1, V2, they look at your septum. This is your interventricular septum. V3, V4, it's anterior wall. Actually, V1 to V4 is anterior. My main thing is V1, V2 septum is looked at in detail. V5, V6 looks at the lateral part of the left ventricular wall. Okay, so coming back to the bipolar leads and unipolar leads, like bipolar lead, as I mentioned, it measures the voltage between the two different parts of the body. The unipolar leads, like, we just focus on only one aspect, but there's a virtual reference point. Okay. So in the ECG leads, or is the ECG tracing on trace paper, like you'll have a 12 leads in this fashion, like 3 limb leads, 3 augmented limb leads, and 6 precordial leads. Those will be labeled as L1 limb, L1, L2, L3, AVR, AVL, AVF, and V1 to V6. Yeah, so this is another diagrammatic representation of the 6 chest leads. Sometimes we have to go and do the right-sided leads. Usually we do the left-sided leads. Sometimes in case of dextrocardia, where your heart is placed on the right side instead of the left side, you tend to do. Also, when you suspect a right ventricular infarction, or like very posterior wall myocardial infarction, then you tend to do the ECG tracing further down, and it just goes. So it just goes up to the back as well. Yeah, this is a lead, like we, apart from the V6, just V7, V8, V9, we could go down to get the posterior wall of the left. This is how the ECG, the leads on the ECG tracing looks like. The first thing that comes on the ECG paper is lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 to V6 in this patient. So the idea of each leads is they look at different parts of your heart chambers, especially your left ventricle, and knowing what is going on in the ECG, we could make out which which particular aspect of the heart is involved, whether it's septum or left ventricle, anterior wall or lateral wall or inferior wall. So the leads L1 and V5, V6 corresponds to the lateral wall of the left ventricle. Lead 2, 3, and AVF. The letter AV, A stands for augmented vector, and this is the left, there's a right, and there's a foot. So 2-3 AVF, they look at the inferior wall of the left ventricle. If you go from like V3 onwards to V4, V5 onwards, they look at the anterior aspect or anterior wall of the left ventricle. So the idea of knowing this one is when you read an ECG, if somebody comes to you with a chest pain, after knowing whether the respiration has ST elevation or depression, then we can know which side of the heart muscle is involved, or the heart attack is happening which side, which wall of the heart. So this is another representation where you could see the colored areas, V3, V4 anterior wall. The lateral wall has been highlighted here. The inferior wall of the left ventricle is in shadow here. Before I move on, I like to know whether am I too fast or is it too complicated, or shall we continue
No, sir.
session? Just wanted to
Fine, sir.
be able to follow. Yeah.
Yes, sir.
Okay. Thank you. So this is just a final summary of how they all. Okay. So now we're coming to how we read the ECG. First things first, like you should know whether the ECG is done properly. So far we looked at how the ECG is done, like how many leads, what are the lead, like the names and all. Now, like next few slides, we are going to look at why we need to read the ECG, or what are the things which we have to focus or concentrate on the ECG. It's called the Professor Chamberlain's rule. The first thing is like when you look at the if you remember, we discussed about the P wave should be followed by the QRS complex and the T wave. So there is a certain duration for each one of these things. So if you look at this the complex, like that looks like a nice and smooth, like upward on the spikes are there. So if you remember, like I was telling about there's a meaning for each waves. Like also, if you look at the waveform size also matters. Like it shouldn't be too long or too short, the duration. That's why it's been reflected on the x-axis and y-axis on the ECG trace. P wave should be normally less than 80 milliseconds. The PR interval should be between 120 to 200 milliseconds. The QRS complex, when I say the PR interval, means this is highlighted between these areas. The QRS complex should be between 80 to 110 milliseconds, not more than that. Because if it's broad, if you remember, like I'm sure you must have read in your medicine textbooks about broad complex tachycardia and other complex. So why we need to know all these things is like when you're going to classify as something as a narrow or broad, so you need to know the duration or whether is it whether it's normal range or not. So also I explained to you about the little squares, like so the PR interval should be between 3 to 5 small squares. So the width of the QRS complex should be less than 110 milliseconds or less than 3 small squares on the ECG paper. One more important thing is like when we do the ECG, sometimes we can misplace or we can keep the leads in the wrong position. So how do we know that the ECG trace has been done in the right fashion? Because if you do the tracing wrong, like you may not be able to, first of all, you may not be able to interpret or get an accurate reading. And the next thing is like, you won't be all waves are negative or downward pointing in AVIA. That's a normal ECG. Another thing is like when you look at the chest leads, which is from a lead V1 to V6, the QRS complex should gradually grow taller. But if it stays like this all through, or no, if it goes opposite side, that means it's abnormal. It should, if you look at this is a isoelectric or this is a baseline, and this complexes gradually get taller as we go along from V1 to V6. Just skip this. This is just the same thing which I explained, whether the ECG trace is the leads are placed correctly or not. The P wave should be upright in lead V1, V2, and from V2 to V6. Sometimes you can get negative P wave or flat P wave in V1. That can be a normal variant. So usually the Q waves are very small. Like, you may not be able to take notice of it. If it's long or if it's tall, then that means that it's pathological Q waves. And usually they are very tiny, like less than 0.4 seconds, in width. That's almost less than one small square. Look at these small squares inside the big square. This is another ECG just to say whether the ECG trace is done, that leads correctly based on the T wave must be in upright position in lead 1, V2 and V2 to V6, the T waves. We're talking about the T wave now. We moved on from the QRS complex. Just the summary of what we discussed just now. So if the QRS complex shows the Q wave more than 2 millimeter deep or 1 millimeter wide, that means it's not a normal variant, it's pathological Q wave. So ST segment, coming on to the ST segment, ST segment should be flat. That's isoelectric, that should be falling on the baseline if you draw like from the P wave like onwards. If there is any elevation or depression of more than 1 millimeter, that's significant and that's pathological. You must have heard about the J point. J point is the junction or the starting point after the QRS complexes before the ST segment. Yeah, so this is isoelectric line. In this you can see the QR is a QR wave, and the S wave hasn't fallen. It should have ideally fallen like here, but just stopped. It's an ST elevation, and this is a J point, and this is the ST segment, and it falls on the T wave as well. Like if there are various versions, which you could see when you get a patient with a heart attack or acute myocardial infarction. There's a various pattern you could encounter like this, depending upon what stage of the heart attack they are or infarction. There's something called evaluation of the ECG changes as the heart attack gets delayed or during the course. There's something called QT interval. That's also significant. Like sometimes it can be pathological. Like the normal QT interval should be between 0.35 to 0.45 seconds. It shouldn't be too short or too long. We just skip the details about QT interval for now. When we discuss the bundle branch block, we are going to discuss in detail why this QT interval is important. Yeah, this is just a QT interval that ranges from the start of the Q wave to the end of the T wave. Also, if you look at this ECG, the P wave, QRS complex, T wave, and there's only a small hump. There's a small called U wave. UAs can happen in hypothermia, the hypokalemia. So that's one of the pointers for the UA. But usually you can't see in a normal ECG, like you can see P wave, QRS complex and T wave, but UA may not be appear in the normal ECG. Sometimes you can get, but you have to look for the causes of the UA, such as hypokalemia and all. This is just a diagrammatic representation of the heart, which is the anterior wall. Main thing is, if you look at the ECG, the main focus is on the left ventricle, especially all the chambers. This left ventricle, the way its position is like close to the surface, and the leads are able to give us an idea about whether the anterior wall has a heart attack, or inferior wall is affected, or the lateral wall of the left ventricle. All this is the left ventricle mainly. This is just a summary of the ECG, the trace, how it looks like. This is a P wave, followed by QRS complexes. This is a J point, which I explained to you. It's just start of the ST segment, and the T wave and the U wave. This is a normal looking ECG, but this morphology can change according to which lead you're looking at. The thing is, like, we need to know how are we going to look at the heart rate. Most of the ECG these days, like, it will have an the heart rate printed on the sheet itself, so you don't need to worry. But sometimes, like, if there's it's not labeled, then you will need to know how I'm going to calculate the ECG, the heart rate. So there's two different ways you could do, all the simple ways you could do. You can count the number of the big boxes between the two QRS complex and divide this by 300. Or if you're able to, if the RR interval, that's the peak spike, doesn't fall into the big box boundary, then if it falls in the small box, then you can use another formula that's divided by 1500. That gives an idea about number of, for example, like this is on spike, this is RR interval. If you look at this, it's 1, 2, 3, 4, 5, 6. Okay. So there are 6 big boxes between these two heart interval. So the ECG score will be like 300 divided by 6 will give 50 heart rate. So if you look at this, but in this case, it's a bit more easier, where you can see this almost the same level. But if this spike falls here and if it falls there, then you will be able to count this as big boxes. You have to count the small boxes. Then you have to use the formula 1500 by number of small squares. For example, in this one, each small square contains 5, each big square contains 5 small squares. Sorry, 1, 2, 3, 4, 5. Here you can almost say that, like 30 or whatever the number, that will be easier. So if the heart rate is like rapid like this, then in this one it's a regular, so it's easy. You can say this one almost 1.5. So it's one big box and another half box is here. So 300 by 1.5 gives you 200 heartbeat. So it's tachycardia. So if you look at just a simple way to know, like, if you have only one big box between two spikes or the peaks, then your heart rate is 300. If you have two small boxes, then it becomes heart rate becomes 150. That's 300 by 2. If you have 3 big boxes between those 2 spikes, then it's 100. So likewise, you can easily calculate. We'll skip this for the time being because it's very rapid. So we are going to work out about the bundle branch block and the heart attack ECGs in the further session. Yeah, this is just summary of the heart rate which I explained to you, the spikes and how you do it. Yeah, if it falls on the the big box line, it's easy. Here you can see the spikes fall exactly on the big line. So there's two big boxes between this. It's 300 by 2. It's 150 heart rate. And you could see this is the ST segment. Here it's depressed. It's not on the isoelectric line. When your heart goes fast or it's tachycardia, sometimes you can see but we have to correlate with the other leads, whether it's in one lead or it's all throughout, or rest of the leads as well. You must have heard something about QRS, axis. What it means is like, it's because your left ventricle, their cardiac conduction goes from the atria to the ventricle. There's an axis, and which we need to know, like to know whether the conduction is in the right pathway. The normal QRS complex, or the axis, varies from minus 30 degrees to actually it says like 90, but it is up to 105 degrees positive is normal. Anything less than is minus 30 is referred to as like left axis deviation, and anything more than this 105 is like right axis deviation. You don't need to worry about how to calculate, but for the basic level, there's something called a rule of thumb, how you know whether this axis is normal. If you look at lead 1 and lead 2, let me go back to the ECG and show you. If you look at these two ECG, is lead 1 and lead 2, both the plexus are upright, that means positive, that means it's a normal axis. You just remember, like lead 1 as your left thumb and lead 2 as your right thumb. If the lead 1, the QRS complex is mostly negative, then that means that your right thumb is pointing upwards. That means that it's a right axis deviation. Likewise, if the lead 1 is upright, the QRS complex is upright, and the lead 2, the QRS complex is downgoing, that means your left thumb is upright. That means it's a left axis deviation. This is a simple rule of thumb. But to know exactly how much degree, there's a calculation, which if you want, I can discuss later. But I don't think we need to put too much emphasis and complicate at this stage on the basic level. Yeah, this is the approach or formula we use, but let's keep it for the time being. If you look at this, it's predominantly, though its complex is small, but it's positive. If you look at this one, the complex is like whatever goes below that line is a negative one, but the one above the line is a positive one. So this is the normal axis. Yeah, this is a way to figure out how much exactly is axis. The reason why we need to know how to calculate the heart rate is, if you look at this ECG, it's not a regular, it's irregular. That means you won't have an accurate heart rate, even the printed one won't give you, sometimes it will leave the heart rate as blank. So you have to calculate. So for that only use a formula, which we discussed, 300 by a number of big squares, or 1500 by number of small squares. And the important thing why we need to look at the P wave is, the P wave should be followed by QRS complexes. If the P wave is missing, or if the P wave is false on the QRS complex or afterwards, that means it's abnormal. So it can be various reasons. The P wave can be missing. If it's missing, then it's atrial fibrillation. As in this case, you won't be able to figure out, is there any definite P wave. You could see a lot of undulations, but they are not P waves. They're just disturbances, because the heart is contracting rapidly, roughly about 100 beats per minute in this case. So it's an atrial fibrillation. So yeah, coming to the end of the basic session. So my idea was just to cover how you record an ECG, how many leads you place, or where do you place the leads, and how to know whether the leads are placed correctly or not. That's the main role. And there is, as I mentioned earlier, the ECG itself is a very large topic or big topic, and we could take hours and hours of ECG. And I'm planning to cover the rest of the ECG mainly I'm just covering in the next session is like how to identify a heart attack or like myocardial infarction or like other things, arrhythmias, bradyarrhythmias and tachyarrhythmias like bradycardia, atrial fibrillation, and ventricular fibrillation, ventricular tachycardia, bundle branch block. So we're going to discuss depending upon how you're able to feel comfortable. I don't want to overload with the too complicated stuff straight away. So that's why I wanted to like, though I was allocated in a 1 hour session, I just wanted to finish before that. So like, and I would like to take any questions. If you have any doubts, you can ask me. Feel free to ask me.
The difference between segment and interval, sir.
So, sorry, the voice is breaking. Sorry, may I know your name? Sorry.
Shakti, sir.
Please go on, yeah.
So, what is the difference between segment and an interval, sir?
Segment. Segment is, let me go back to segment is, for example, ST segment, that's a term used for like showing the interval is the duration. Let me show the ECG there, it'll be easy for you to understand. Okay. If you look at this, ST segment means it's almost the same. The term is the same, but the interval is the duration. So ST segment is it's a broad term. What we are looking at is the whether it's elevated or depressed, or is a term. But the segment and they are both the same, but how we are measuring is slightly different. If you look at this PR segment, actually like the PR segment, if you look at this ECG, they are given slightly differently. But the measurement, the PR interval is starts from the P wave until the start of the, this is not accurate, this should be here, this line should be here. So they're both the same, but they are just been labeled for different reasons. Like interval means like the same thing, but the duration. Complex is the term, like this is just the shape. Segment and the interval are almost the same, like it's not anything different, but just for the sake of the measurement, because all these measurements are done in the form of milliseconds and seconds on the ECG paper. That's why they said like the interval and the segment. Segment like the segment can be elevated or depressed. For example, if you look at here, ST segment can be elevated or depressed, but you cannot say ST, they are both are equal. ST segment and ST interval are like different, because what is significance is the duration. This is the actual the length, but this is the representation. This segment can be in the normal line, it can be elevated, which will be in a heart attack, or it can be depressed in some kind of another heart attack or instemi they call. That's the basic difference. But they almost mean more or the same, but in a different context. But if you look at ST interval here, you can't say that they both are equal here, because ST segment can be elevated or anything. This gives the duration. This gives a pattern. Segment gives a pattern. The interval gives the time interval between these 2 points, like the start of the S wave or the end of the S wave to the start of the T wave. Am I clear, Shakti?
Yes, sir. Thank you, sir.
Any other questions? But even if you have more questions, like we can always discuss during your subsequent sessions. Today, I just wanted to know like how much the how many classes were taken before, so that I can pitch my discussion or level of discussion. I don't want to go into the higher level or the advanced level to start with. That's why I just wanted to touch upon the basics. Then we can gradually like build upon.
Okay, sir.
If there are no questions, shall we close this session?
Okay, sir.
Thank you very much, friends, for the patient listening, and I hope you enjoyed the session. And if you have any questions, please do let me know. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.